So today we're going to be talking about fungal infections. So this talk is really about how I organize things in my head and how I approach people who have a fungal infection so that it's clear to me about what I should do. So really the talk is going to be first just classifying the different fungi, classifying antifungals, and then some specific diseases, syndromes, or situations you might be in that I think it's important for you guys to know about. So first off, classifying the fungi. So in the kingdom of fungi, I usually separate it in two big broad groups, yeast and mold. Yeast, when you hear that, you should think about buds, you should think about spores. When you hear about mold, that should automatically trigger, hey, hyphae, when you look at it under a microscope. Okay? And then there are certain diseases or certain pathogens that can exist as both yeast and mold, right? They're usually mold in cold, yeast in the heat, right? And so those are the dimorphic fungi, right? So, yeast. So there's two big genotypes of yeast that you're going to see most often. Canada, far and away, is by far like 70 to 80% of what you're going to see, right? There are different types. I highlighted like 5 of them. Albicans, again, the most common one, but the other ones are still cause pathology, and I started 2 of them, Glabrata and Krusei, just to keep that in mind because we're going to talk about it a little bit later. The other one is Cryptococcus. So this is a picture. I don't know if you saw on your boards, but you can. It's very common. It's actually pretty distinct. You basically have this nucleus right in the middle, and then outside of it you have a pretty thick mucoid capsule, which gives you this particular appearance to it, right? And so really the only times you run into Cryptococcus are people who are immunosuppressed, people who have HIV, AIDS, who get either cryptococcal colitis or Cryptococcus meningitis. Otherwise, for someone who's otherwise immunocompetent, we don't really see it a whole lot. All right, so you move on from the yeast to the dimorphic fungi. So these are all the ones that are endemic to certain areas, right? So histo, blasto, coccidio, not in there, but paracoccidio, also sporotrichosis, which comes from the gardeners, that's also a fungi, and it's also dimorphic. These generally don't cause a whole lot of problems for people. It's very rare that you're going to treat histo. It's usually pretty rare you're going to treat coccidio in the Southwest. Usually when you see this, someone has a fever for a couple of days, then they get better. It's usually pretty self-limited, and by the time they go see a doctor, they're already better. Really, the only one that I ever see that sometimes gets treated is blasto. So, for example, like I am diagnosing like 4 or 5 cases of blasto when I was working, and they're all very young. They're all immunocompetent, but they had pretty severe disease. In fact, one of them was a monk. So, I mean, it's not like it's something that you just get exposed to and then suddenly become very ill. Looking at it under a microscope, I think, is actually a little difficult. Some of them stand out, but some of them don't. So for example, this one. Let's test around. Hassan, what is this? No, you're actually right. This is not a trick question. This is actually coccidio. So you have the spherules, and then you also have the little spores, and endospores, and then it slowly gets released, so these are your spores. So this is just coccidio. Arjun, what's that? That is blasto. Yeah. The broad-based budding yeast, maybe you see it up here, that's a little broad, that one's a little bit broad. But yeah. Histo, it's not up on the screen, but it's usually a little bit smaller. It's like half the size or a third of the size of blasto. They're usually narrow-based budding yeast rather than broad-based. But it can be very tricky to see. So you move on from dimorphic. Again, remember, yeast in the heat, mold in the cold. So in the body, they're going to be yeast when you see it. Move over to molds. So the biggest mold that you're going to run into is the aspergillus. Right? There's several different types. I just put on 4 here. And then this right here is just an illustration, a 3D illustration of what it looks like. with the hyphae out here, and then these are the ends of the hyphae. And then the other one's mucor. If you see one with mucor, I've only seen 2 people when they both died. It's pretty severe disease. People can get sinusitis, people can get orbital problems. If there's anything on the face, it's usually pretty bad. We usually see it a lot in those who are immunosuppressed as well. And it can be pretty devastating. So if you ever see someone who has it, or if you ever Google pictures of it, it can be really, really, really bad. Okay? So that's the way I classify them for me. And it's important that you do that because the way I classify antifungals is based on whether it's a yeast or a mold. And so if you go to antifungals, there's actually a few more categories that I include, but that's because this talk is really about systemic infections. And so for some of the things that are more topical, like nystatin, that's a polyene, but I didn't put it on here. Gursifulvin, I didn't put that on here, that you use for like tinea pedis and different types of things. So the first one we're going to go into is actually the azoles. So going back, so this is our fungal cell wall. The azoles, the way they work is they basically bind to a 14-alpha demethylase that prevent the formation of ergosterol. And ergosterol is needed to, in the cell membrane, or in the cell wall, basically to stabilize it. And so if you inhibit the synthesis of it, then you destabilize the membrane and eventually it dies. Right? So we're going to go to our first generation. Now, I classify these in generations, but that is not a formal classification. That's just the way I do it so that I can keep straight in my mind what treats what. The first generation is really for topical stuff, right? So someone has athlete's foot, someone has a groin infection, whatever, diaper rash. You use one of these topically, whether it's a cream or a powder or what have you, to treat it. Yeah. Really the only systemic one that can be used, or that has a systemic use, is ketoconazole. But no one uses ketoconazole systemically anymore because it's got some side effects that come along with it. And because of the newer generations, the side effect profile is not really worth it. Really, there's only one time that I see ketoconazole used systemically anymore. I don't know if anyone takes a guess. Richard, you want to take a guess about when you would use it? It's okay. All right. Huh? Well, something that you would use it for that has no antifungal purpose whatsoever. Huh? Yeah, exactly. It's for people with prostate cancer, right? It's got an anti-androgen effect to it, and so that's why people use it. But really, that's the only time I ever see it used orally anymore. Okay. So you move on from the first generation. We need something more systemic, right? We have systemic fungal infections. We need something that's going to work systemically that doesn't have the side effects. So we used fluconazole. So fluconazole is mostly all yeast. Okay? So if someone has cryptococcal meningitis, Cryptococcus is a yeast. Normally they get put on Ampho B first because it's a serious infection, and then they can transition not to Vori, not to Pasi, not to Itra, but to fluconazole usually, right? Because this is all yeast. The next generation I say is 2.5, Itra. So once you get to this point, you're getting more mold coverage. Okay, so if someone has Aspergillus mold, also 2.5 is kind of where you use the dimorphic, what you use for all the dimorphic fungi. So for histo, blasto, coccidio, all of those, usually the first line treatment for mild or moderate disease is actually Itra. And then you move further on to the third generation. So in the third generation, they have some yeast coverage, but typically you're going to be using it for molds. So anyone who has mucor, anyone who has aspergillus, in general you're going to be using one of these three, Vori, Pasi, or Crescemba. Okay. And so, like I said, this is the way I kind of organize it. There are caveats to this. So if you remember back when I was talking about Canada, I had put a star next to a couple of them, Glabrata and Krusei. That's because they have a pretty predictable resistance pattern to fluconazole. And so for Glabrata, they typically tell you that you need to use an Echinocandin, and then for Krusei, they usually tell you that you can either use an Echinocandin or you actually use one of these, Vori or Posi. All right. Next up, going back to our wall. So one way was to prevent ergosterol from being synthesized. Well, the next category of medicines work on the 1,3 glucan synthase, and those would be the Echinocandins. There's 3 of them on the market: Caspo, Nigella, and Mica. Depends on which hospital you're at and what's on their formulary. For here, we use micafungin, I think a majority of the time, even at the VA as well. They cover mostly yeast, and they're usually mostly used for systemic yeast infections. They do have some activity against Aspergillus, but the activity of Vori and Posi and Cresemba is so much better and so much higher than the Echinocandins that typically, even if someone has Aspergillus and they have worry about using Vori, the benefits far outweigh the risks and they'll still use it. Really, the only issue with the Echinocandins and using them is where they don't go, right? So they do not get into the GU system and they do not get into the CNS. So I was rounding this weekend and someone told me, hey, we're going yeast from the lung and we're going yeast from the urine, right? I said, we've got 2 different sources we put on micafungin. Well, you got to think really hard about treating the yeast in the sputum. And then if they did have yeast in urine, you're not treating it, right? So you had to put them on fluconazole if you really want to treat this supposed Candida UTI. All right, that's our cell wall. So the Echinocandins hit the synthase. The azoles prevent the formation of ergosterol. Lastly, you have the Polyenes, which is basically amphotericin B, and what that to it, it's almost like a pore, so that things can move equally in and out. That stabilizes the cell wall, and people die, and that's how it dies. Now, the issues with amphotericin, it's got a bunch of toxicities, it's got a bunch of side effects. You look and it's called amphoterrible for a reason for some people. So that's why its use is pretty limited to those who have very serious infections. All right. So that's how I classify the fungi, that's how I classify the antifungals. And then really that should get you most of the way in just in terms of treating things day to day. All right. But there are specific things that I would pay attention to. All right. Now, one thing that pops up a lot is kind of Aspergillus. And when I think about Aspergillus, I think about it as a semi-continuous spectrum of disease. Right? Probably the easiest part, the first part of that is, or at least the minor part of that, is kind of allergies. Now, you can be allergic to Aspergillus, but you can also have this type of syndrome connected to other fungi. So you can get this with histo, you can get this with blasto. But the reason we say it with Aspergillus is because it happens probably the most often. I listed here kind of the criteria that they had made in terms of diagnosing ABPA. But in all honesty, I think when we see a constellation of symptoms or signs, so if someone has a really high IgE, someone has Aspergillus antibodies, and they have a pre-existing like asthma, I think most people will treat it. Yeah. The other part of that is extrinsic allergic alveoli. So someone somewhere, there's a bunch of mold around and they breathe in this huge mold burden, and sometimes they can have just like a little flare-up, and then you get away from that and then you calm back down. So in terms of treating these, this one in particular, there's different thoughts about it. There are certain criteria from different societies. ATS has something, IDSA has something. ATS says if you give them basically steroids for mild, heart disease, that should be enough. IDSA kind of says that if you have ABP at all, not only do you need steroids, but you probably should take itraconazole as well. I personally would say that I think that the studies I have looked at say that treating it with ITRA actually benefits people and gives people a little bit better symptom relief. So I honestly say that I usually give people ITRA if I'm going to treat this. But just know that there are people out there who won't, and it's not that it's wrong, it's how they practice. If you move on from that, then you get into more of the chronic Aspergillus symptoms or syndromes. Probably the one that we see somewhat often, Aspergilloma. I'm not saying you necessarily need to do anything about it. Really, the biggest complication, the biggest problem that we'll see is someone has hemoptysis from it. And so if they do, then you probably should do something. What do? Well, if possible, you can try to resect it. Right? If you can't, because their lungs are too bad, maybe they're not stable enough, there are other things you can try. So some people will try a bronchial artery embolization to try and deal with this. That might just be a temporizing measure. Some people can actually instill amphotericin B into the cavity to try and get that to work. That also might be just kind of pausing things a little bit, and then it might happen again. But really, this is kind of difficult. If they really can't get it resected and that's all you got, that's all you have to do. Or that's all you can do. Other things to note, Aspergillus nodule. It's tough. You know, some of these things can actually look like a lung cancer, like a malignant nodule. And really, you don't know, you can't tell a difference until you cut it out and take a look. And then you have these other little syndromes. These are probably where the point where you say, do I need to go from watching, do I need to start treating? And so those are kind of cavitary aspergillosis, fibrosing aspergillosis, necrotizing aspergillosis. Some people will call this last one sub-invasive aspergillosis. And so for these, typically you'll start usually either voriconazole, some people will start itraconazole, and the minute you stop it, usually they have a flare-up again. And so some of these people can be on Vori indefinitely, because every time you stop it, their symptoms get worse. And if they continue to get worse, then they'll keep on progressing to a point where it goes necrotizing, and then maybe it can even turn into basically kind of invasive aspergillosis. All right. Invasive aspergillosis, we usually see it in immunocompromised patients. They're usually the bone marrow transplant people, the solid organ transplant people. You can try to reverse the immune suppression, but for most of these people, it's kind of necessary, so you can't do anything about it. If they're severely neutropenic and they've been neutropenic for a long time, you can try to stimulate that as well to try to help with the aspergillus. Otherwise, you're just kind of stuck. You kind of treat it, you hope for the best. There's really not much. I'll be honest, when someone has invasive aspergillus, I normally, especially when they're on the bone marrow transplant floor, I normally don't see a good outcome. This, silver stain, this is just all the different hyphae and the acute branching here and maybe up there. Yeah, so this is just aspergillus, and this is how I think about aspergillus. Like I said, I usually think about it as a spectrum of disease. And once you get started on that path or on that spectrum, sometimes it's hard to get off. A couple other ones that you should think about. Fibrosing myastenitis. This is not only related to fungal infections, but it can be something from you getting histo. But just be note that it's something you get in sarcoid and other things as well. What do you do for it? It's not what you can do, honestly. You can try to give them itraconazole. Some people they say you should at least try. I had one case that it was so big and they were so large that they were encasing and they were compressing the pulmonary arteries as well as her main bronchi. And we sent her to the surgeon. The surgeon said, try ITRA. We tried ITRA for like 12 weeks. It didn't work. Not that he thought it would. But then when we said, hey, go to surgery, he balked at it. He's like, well, I'm not going to take her to surgery because this is like cement. That's what he said. He's like, you know, this is a high-risk surgery. You're basically trying to take out cement from someone's mediastinum that's eroding into someone's airway, that's eroding into someone's pulmonary artery, and the likelihood is that they could easily bleed out because you're trying to do surgery on this. Like, I can't blunt dissect it. I don't have much to offer. You have to go to a surgeon who's really specialized in the mediastinum, or you can try some stenting, but otherwise you're kind of stuck. So you should know about that one. Something else you should know, pregnant person. So despite the fact that we say it's amphoterrible and has a bunch of side effects, it's the only medicine that's category B. All the azoles are C, even Vori is D. All the Echinocandins are C. And so, you know, if you got someone who's pregnant and they got blasto, even though you might want to start Itra, you're actually supposed to start Ampho B. Okay. Last one, candidemia. I've run into this a few times since I've been back, and there's always a problem with something. Sometimes we don't get an echo. The biggest thing that I see people miss is we don't consult opto to get an eye exam, right? Because if someone has endoophthalmitis from their yeast, then you can't use mycofungin because it doesn't penetrate the sinus, and it doesn't penetrate the eye either. So you need to be on fluconazole if you're going to do that. So this right here, just so you know, say someone has mold in their eye. I kind of said that the voriconazole, posaconazole, those or the Echinocandins don't get into the eye very well. So for the mold, what they actually do is they will basically inject Vori or inject Ampho B into the vitreous cavity to try to treat it. Just so you know. All right. That's actually, it was a lot shorter than I thought it was going to be. All right, any questions, guys? That's only one.
The Echinocandins don't penetrate the CNS and
the eye and the GU system. So if you got anything in there, it's got to be an azole.
I have a comment. The aspergilloma, the patient has an is indication for surgery, but it is a very difficult surgery technically for the surgeons because it is angioinvasive. It tends to bleed a lot. So you talk to the surgeon, they will think twice before operating these patients.
All right, that's it. That's all I got. We're going to get out early. That was a lot harder on Pretzi. All right.
Azoles. How long can you leave people on? I mean, I know.
As long as you need to.
Okay, as long as you need to. Has that been anything like for like? I mean, if, other than the liver side effects and stuff like that, you don't get anything if you have to leave people on it for like really extended period of times.
No, I mean, so the biggest thing they always tell you a lot of child is for the liver enzymes and stuff. You know, with the Vori and the Posi, especially the IV formulations, it comes in cyclodextrin. And so some people thought that cyclodextrin, if it accumulates in someone who's got kidney disease, that's going to cause more liver problems or more renal function problems. But there's studies about that, and it hasn't been shown to be true. So.
I have two things to say. So we had a patient in ICU at candidemia, endophthalmitis. He was put on fluconazole after diagnosis. Do you have any timeline for 2 weeks, 3 weeks? How long do you give antifungals for?
So it depends too, right? They had endocarditis. Yeah, it's going to be long, and they have to get either the vegetation's got to come out or it's got to go away. So some people, they're on it for a long time because the surgeon doesn't want to cut it out either.
What's the role of fungitel and
You're right.
cultures take long?
I didn't talk about it. So there's a couple other ones, fungitel and galactomannan, right? So fungitel tests for the 1,3 beta-D-glucan, basically the stuff in the cell wall. So if you suspect that someone has an invasive infection, you can use it to try to help. I haven't found it to be all that useful personally. The galactomannan I found to be more useful We can test for it in the serum, or you can test it in the BAL too. I think it's been mostly studied and mostly verified in those who have bone marrow transplant. But we use it for all kinds of different things. Depending on when they give you a result, they always say positive or negative. But they based it on the optical density. And so depending on what cutoff you use for it, it's going to say the sensitivity and specificity of it. So some people use a really high number, and when you do, the chance of them having aspergillosis and it being a problem is a lot higher. I'll be honest, I don't remember what our cutoff here at U of L is, but if you use a low number for that kind of cutoff, you'll catch a lot. But is it really invasive aspergillus? Can't tell. Plus, you have the problem of it being, you have the problem with it being false positives from different things. So a lot of antibiotics, Zosyn especially, cause a false positive. Other fungi or other fungal infections can cause a false positive, and you think it's aspergillus, that's actually something else. So I'm sorry.
The galactomana is more specific for aspergillus. The fungal is kind of more specific. But my experience has not been good with those tests. By the time they come, it's already too late, and the galactomana has the false positive above with beta-lactam right? So it's a problem. Candidemia is a diagnosis that a lot of times I've seen us doing the diagnosis when the patient is already dead, or when the patient is super sick. I cannot tell you how many times I have had patients who we found out the patient had candidemia when they're dead. So there are clinical prediction rules that you can use, like if the patient has abdominal surgery, if the patient is on steroids, but they are not that great. I think the next step will be PCR-based tests. We're going to have PCR-based tests, and we're going to be able to diagnose these fungal infections within 24 hours. It's coming.
One thing I was going to say is for Aspergillus, for instance, if you combine the PCR with the, which is available, PCR,
The galactomana.
for Aspergillus and galactomana, the results are much better. Yeah, you have a better predictive value.
Mm-hmm.
So that's, another thing I was going to mention is that in patients with crypto, for instance, we have a patient in the VA that the removal of a nodule that was malignant turned out to be crypto. So you're obligated to do lumbar puncture in all these patients.
Yep.
Because you have the predilection for going to the head. So that's, we did, and that was negative. The antigen in the CSF was negative.
Negative.
That was just yesterday.
It's put on fluconazole, all right? Or AFOB.
That was one of the, so that for that case, that was the question was, so they removed the nodule that was crypto.
Yeah.
So
And then we did, and then the surgeon said, well, we're finished. He said, no, we're not finished. We have to treat it. He needed to let fluconazole, so he's not isoconazole now. But on top of that, we did the lumbar puncture. The lumbar puncture showed antigen negative. But the antigen was positive in the blood right away.
I mean, I guess technically he's right. If you cut it out, you're done. But some people will treat it anyways because they worry about spillage into the cavity and stuff too.
No, what about treating? We're treating for several weeks.
Yeah.
6 weeks or something like this.
So, I treat it. All right. Anything else? All right. Thank you.
Thank you.